Research Service. I'm pleased to be moderating and acting as discussion for this session on rural healthcare availability. So I think without spending more time, I'll get started. And we have 4 presenters today. So I'm going to give each presenter 15 minutes, and I'll give you 5 minutes and then 2-minute warning. And then there'll be a timer that goes off. So we'll start with Claudia will be presenting the first group.
All right. Good morning. Thank you all so much for being here today. My name is Claudia Rose, and I am a graduate research assistant at Oklahoma State University. I will be presenting to you this research paper that I have been working on with Dr. Brian Whitaker from Oklahoma State University and Dr. Allison Davis from the University of Kentucky. It's titled Early Adoption of Telehealth and Hospital Revenue Changes During COVID-19. So the objective of this study is to determine whether implementing telehealth and remote patient monitoring before the onset of the COVID-19 pandemic had an impact on revenue changes during the early phases of the pandemic, particularly from 2019 to 2020. And also to compare these results between rural and urban hospitals to see if they differ. I'm going to start with some quick definitions so that we're all on the same page about what we are talking about. Telehealth, as many of you already know, is the use of electronic information and telecommunication technologies to provide long-distance healthcare. And remote patient monitoring is the use of digital technology to gather physiologic data about a patient in one location, for instance, in the patient's home, and to transmit that information to a different location, for instance, a hospital or a doctor's office for analysis. By 2019, telehealth adoption was growing at a very modest rate. This because of many different patient and provider-related barriers. However, as we all know, on January of 2020, we had a big change in our lives, and the Department of Health and Human Services declared a public health emergency due to COVID-19. On March of the same year, the Centers for Medicare and Medicaid Services declared that the use of telehealth was going to be vital to combat COVID-19. And around the same time, both the CMS and the HHS encouraged private insurance to make the use of telehealth more available. These rapid changes in regulation around telehealth and the removal of many barriers led to a greater acceptance and use of telehealth that we haven't seen before. And the COVID-19 had very important implications, not just for healthcare access, but for revenue generation for hospitals and practices. And telehealth was expected not only to provide healthcare access, but also to mitigate some of the revenue losses that were expected as part of the COVID-19 pandemic. The literature on telehealth has been growing a lot in recent years. However, there have been difficulties in demonstrating the financial value of telehealth activities. And there have been a few studies on the relationship between telehealth implementation and revenue changes during COVID. However, most of these studies have been simulations, or they have focused on a particular medical specialty or a particular state in the United States. So to our knowledge, this is the first study to use US level, hospital level data to measure how telehealth implementation before COVID-19 influenced revenue changes from 2019 to 2020. So our data on telehealth and remote patient monitoring information was retrieved from the American Hospital Association Annual Survey of Hospitals Information Technology Supplement. And the way we measured telehealth and remote patient monitoring implementation was by measuring whether hospitals had EHRs, electronic health records, that allowed for telehealth and remote patient monitoring availability. Our revenue data came from the American Hospital Directory, and we gathered data on gross patient, inpatient, outpatient, and net patient revenue. from 2019 and 2020. And our control variables were the case mix index in 2020, the general hospital status in 2020, and the changes in the number of beds, employees, acute days, and discharges from 2019 to 2020. And we obtained that data from the American Hospital Directory as well. Our final result was a cross-sectional data set of 1,997 hospitals, and about 1/3 of the hospitals in our data set are rural, and we consider a hospital rural if its rural-urban continuum code was greater or equal than 4. Here are a few summary statistics. On our top table, we can see the telehealth and remote patient monitoring implementation in 2019. As we can see, about 75% of hospitals had telehealth implemented by 2019, and a considerably smaller proportion of hospitals had remote patient monitoring ability, about 50%, and there were not significant differences between rural and urban hospitals in terms of implementation. The bottom table shows us the hospitals that experienced revenue decreases from 2019 to 2020. About 50% of the hospitals in our data set experienced revenue decreases in all revenue categories. However, as we can see, rural hospitals experience significantly greater decreases compared to urban hospitals. So here are our methods, and I have to go very quickly through our paper, but we can talk more about it later. In order to establish this relationship between telehealth implementation and changes in revenue, we used simple linear regressions on our cross-sectional data set, where our dependent variable was the percentage change in revenue from 2019 to 2020. We have our set of controls, and we have dummy variables for telehealth and remote patient monitoring implementation. So our main hypothesis is that our estimated coefficients for our variables of interest, telehealth and remote patient monitoring implementation, are positive and statistically significant. We believe that hospitals that adopted telehealth and remote patient monitoring before the pandemic were able to respond in a timely manner to the emergency and were able to have revenue generating opportunities. Here we have a very brief figure that explains the relationship between the percentage change in discharges and the percentage change in gross patient revenue. And as we can see, the relationship is stronger for hospitals that did not implement telehealth. So we believe that hospitals that implemented telehealth before the pandemic were provided with revenue opportunities in spite of these declines of discharges. So we performed our analysis for our different revenue categories, and we also run these specifications for the full data set and for rural and urban hospitals separately to see whether there were significant differences in the estimated coefficients. And here are the results for gross patient revenue percentage changes. As we can see, the implementation of telehealth before the COVID-19 pandemic is associated with significant increases in revenue for both the full data set and for rural and urban hospitals. However, contrary to our expectations, we find that remote patient monitoring implementation before the pandemic is associated with significant decreases in revenue. And I'm going to talk about this a little more later. Here are the results for net patient revenue percentage changes. Here too, we find that telehealth is associated with significant increases in revenue, however, smaller than those for gross patient revenue. Here are our results for inpatient revenue changes. Telehealth, again, is associated with significant increases in revenue, both for the full data set and for urban hospitals. And finally, here we have our results for outpatient revenue changes. Again, telehealth is associated with significant increases in revenue for both the full data set and rural and urban hospitals separately. And again, we find that remote patient monitoring implementation is associated with significant decreases in revenue, which is not what we were expecting. So our conclusions is that telehealth implementation before the COVID-19 pandemic is associated with significant increases in revenue as we expected for all revenue categories. However, remote patient monitoring implementation was associated with significant decreases in revenue, in particular gross patient revenue and outpatient revenue, with the greatest decreases found in outpatient revenues. We ran tests for differences in the estimated coefficients for rural and urban hospitals, and we found that there is no evidence that the coefficients are significantly different across geographies. So these results hold for both rural and urban hospitals. So our results support our hypothesis in terms that telehealth is indeed associated with increase in revenue, but we find this surprising result that remote patient monitoring implementation is associated with decreases in revenue. These results suggest that hospitals, in particular rural hospitals, have not been able to monetize these remote patient monitoring interactions. A recent report by the National Policy Center found that nearly half of the states in the country do not have a Medicaid reimbursement for remote patient monitoring implementation. And we believe that this is likely behind these reductions in revenue that we found in our results. So in terms of policy discussion, the COVID-19 pandemic has demonstrated both the potential and the relevance of telehealth. And our results support the claims of telehealth advocates that telehealth could be a tool for hospitals and practices to improve their finances. However, there has been evidence that remote patient monitoring has not been able to be monetized in the same way as telehealth by hospitals and practices. So there is this need to push for insurance reimbursement in this area. Here are some of the limitations of our study. First of all, we defined telehealth and remote patient monitoring implementation as whether the EHR's hospital has this system functionality. There might be other better ways to measure health IT implementation that we didn't consider for this particular study. Also, our metrics only measure whether telehealth and remote patient monitoring is available. So we have limited insight into how hospitals are using telehealth and remote patient monitoring, which would also affect the revenue opportunities for hospitals. And we have limited access to alternative control variables that could also predict revenue changes. So this is also a limitation. And we look at 1-year changes from 2019 to 2020. This was early in the pandemic, so there is additional work needed in order to determine whether these relationships have hold in these later stages of the pandemic. Finally, our sample is limited by hospitals reporting data on telehealth and remote patient monitoring implementation. And since self-selection can occur, we are currently working on a model to predict the propensity of survey response in order to generalize our results. So this is what we're working on currently. And that would be all for me. Are there any questions?
You want the PowerPoint?
Oh, yeah.
Yes. Okay.
Yeah. We have time for questions before that. Yeah. Go ahead. I have a question. Just, did you guys, so you had a large enough N, I'm wondering if you could, or if you have already looked at regional variation. So maybe just controlling for like the census block, or not census block, census region or division, like seeing if the Southeast is worse than the West Coast, or were you able to look at that?
We have not, but that would be a very interesting.
Could be an interesting story just to see if like maybe one region of the country is holding those results in a certain direction.
Oh, sorry.
You keep mentioning gross revenue.
Mhm.
Do you have information on differences in implementing, the cost of implementing telehealth and how that may change the profitability
Right.
of this for the hospital, and whether they're part of a hospital group or whether they're larger compared to smaller, and how that cost of implementation may differ between types or, like Andrew just suggested, maybe regions of the country? Is that information even possible to get?
We don't have that information right now, but it would be an interesting follow-up. We had an article on electronic health record implementation, and we did have information of electronic health record costs. So maybe we could look more into which different sections of EHRs are, implementing different revenue categories.
I'll just add, Cheryl, so this paper only looks at the revenue side of things. She had the first paper in her dissertation looked at the difference between EHRs and false.
Okay.
And it's not, so we did not see that.
One more question. You were expecting an increase of revenue from patient monitoring, but I was expecting what you all said. Because, one time patient remotely is not amenable for many diseases and a lot of things. Why did you expect an increase? Why I was expecting that?
Right. So because there was such an important decrease in discharges and the number of patients actually being treated both inpatient and outpatient, we were expecting that these revenue decreases that were a result of this decrease in both inpatient and outpatient services because of COVID could be maybe not entirely, I forgot the word, compensated, but at least there would be some revenue generating opportunities by having telehealth availability. So all of these outpatient visits that had to be canceled, at least some of those could go through telehealth.
Okay, Councilor will have some comments. Thanks, Claudia.
Thank you.
So let's see. So I appreciated the opportunity to read this paper, and the paper, Brian provided the paper to me a few weeks ago, so that was helpful. So the question was, what were the impacts of hospitals' use of telehealth and remote patient monitoring in 2019 on changes in hospital revenues over 1 year period? And the key findings, as Claudia emphasized, were that telehealth was associated with more growth in hospital revenues, while remote patient monitoring was associated with less growth, and the results were similar across rural and urban areas. So I just had some comments and questions, and I have some others that I'll provide you. I had some margin comments and so on some specific things, but I think the paper was very well motivated, and so I appreciated that. I did wonder though, like, you look at the impacts of telehealth prior to the pandemic on changes in revenues, but I wondered, is it possible to look at the effects of the changes in telehealth that occurred during the pandemic, which of course increased quite a bit? So is that possible? I'm sure you probably have concerns about endogeneity and so on. So maybe that's the issue, or maybe I don't know if there's data available on telehealth and remote patient monitoring in 2020. So that could be part of the issue. But most of my questions related to the regression specification, and then how one could interpret some of the findings based on the specification. So one thing that I found a little bit puzzling is that some of the variables were in levels and some of them were in changes. And I wasn't sure like what theory might imply that some variables have an effect in levels and some have an effect in changes. I could see that if you wrote down a first difference model, if you wrote down a model in levels, then your first difference model would all be, the function of changes in variables, unless you have some kind of, disequilibrium kind of phenomenon going on where earlier values of variables have longer term effects on changes. So anyway, I think some thinking about the theory underlying your model might be helpful. And I think since it's not really technically a first difference model because you have some of these variables and levels. So it's not clear to me that the claim that unobservable fixed effects are being differenced out, I'm not sure that's true. But anyway, it requires maybe some more thought about that. Maybe perhaps the most important issue for me was that several of your control variables, like changes in number of beds, employment, discharges and acute days. These are kind of measures of the hospital, sort of the demand for the hospital services overall. And those seem to me to be endogenous variables, but also, and so there's an endogeneity concern, but I'm also concerned that they may be part of the mechanism by which telehealth has an effect on the outcome. I think even the explanation that you gave in response to the question, you were saying, well, there's more, growth potential and so on with telehealth. So you may be, you're only getting the partial effect, in your regressions of telehealth controlling for these other changes in overall demand for the hospital services. And so perhaps that's part of the, maybe in a sense, sort of, you're not getting the total effect. In a sense, you may be sort of biasing downward your effects of remote patient monitoring and telehealth. So it might be part of the story about why you're getting negative impact or effects of remote patient monitoring. And then I also wondered, could you control for location characteristics like population density, access to urban areas and things like that, that may also affect the demand for hospital services and profitability and so on. So anyway, those were just some of the questions that I had that came up. But let's see, what time are we at? We probably should go to the next one, or do we have time for, it's 10:21 right now. So do you feel like we should go to the next?
Yep.
Okay. So I think the next two papers we won't have questions unless they're like quick discuss, or maybe I should just stop for a second and see if Brian may want to respond to, or Claudia, I don't know if you want to respond to any of my comments or
Those
questions.
are good comments. Well, think about those, particularly like that endogeneity with sterile and herbal. I think we need to think about that.
Okay, thanks. Yeah, sorry, I didn't mean to cut off, from responding to the comments. So, all right, so thank you, Claudia, and we'll go to the next paper. So is it Sarah, are you presenting first?
Chelsea,
So I think-
we're gonna flip flop the second and third paper, because they're from the same grant and they're kind of related. And the second paper, what's gonna be the second paper, Chelsea's paper, provides more kind of the background and motivation for the project. So I apologize to those of you who, mucked up the timing, but we're gonna flip. We'll have Chelsea Conley next, and then I think we'll go directly to the next paper, my paper, and then we'll have maybe discussion about both of them together since they are related.
So I forgot to ask, do we have a format for people there are people on Zoom? And should we be, is there a way to check and see if there are any questions from the
Yeah.
audience?
Chelsea,
Let
you wanna
me-
click the Zoom, pop out the Zoom,
Yeah.
real quick and see if there's anything on the chat. Okay, I don't think that.
Can they still see the screen? Is that?
Once
You have to
once
screen share.
Once you hit the.
Where's the screen?
Yeah.
There you go. Yeah.
Okay. So are we good to
And
keep it up?
then I think
And
a little
then-
more, okay. That's fine. Yeah. it's gonna be the height. Sure. All right, you're good to go, Chelsea.
Okay. Good morning. My name is Kelsey Conley. I'm with the USDA Economic Research Service. And this work is titled Growing Rural Health Disadvantage, Increase in Natural Cause Midlife Mortality. This is an overall sort of big project, and sort of why we switched the order is that I'm working with Liz Dobis and David McGranahan at USDA ERS, and in conjunction with this larger SPG grant and University of Missouri folks, and sort of we'll talk about case study things later. But this work is really just an overall big picture view, so kind of like a zoom out view of sort of what's going on with this increase in midlife mortality, specifically for rural areas. So really, big picture, when you look at the age-adjusted all-cause mortality and comparing non-metro and metro areas, we see over time that rural area mortality rates were not always higher than urban areas, right? So when we look back in time around 1968, 1970, we actually see the metro
all-cause mortality rates higher than these urban rates, followed by a period where they were very similar. And then as you look at the time period that we're really interested in to figure out kind of what's going on, is really beginning in 1990, right? We see this divergence. And again, this is all-cause mortality. But we really start to see this divergence in these mortality rates, specifically metro mortality rates are decreasing, and rural mortality rates are sort of staying stagnant, right? So sort of why is this divergence happening? And looking at this gap in rates. A lot of specifically this midlife mortality was brought to the forefront when we talk about the opioid epidemic, right? So those were the big headlines. That's sort of what got people's attention, and this rise in this mortality rate specifically for this working age population, right? So there's been a lot of previous research done on deaths of despair. It's been tied to the drug environment, again, opioid epidemic. David McGranahan did another ERS report that really looked at the opioid crisis and rise in that, as well as others. And again, that was tied specifically in rural areas to these economic downturns, right? So the whole deaths of despair, drugs, alcohol use. But then there's been other papers looking at this overall just general increase in midlife mortality. And again, tied, Case and Deaton tied it to the loss of opportunity, specifically maybe in these rural areas. And other work has looked at women specific and then rural areas. Okay, so, and again, this is an overarching view, and I sort of let the data do the talking in this presentation. So there's not going to be fancy models, but sort of just showing data, overview of sort of what's happening. So again, if we break down sort of, okay, we have this divergence, but now we're breaking it down by age ranges, right? And so we know that this midlife mortality really was a big deal in drugs, but when we look overall, we can see again here comparing metro and non-metro. When you look at breakdown by age cohorts, comparing, so we compared 1999 and 2001 average to 2017 to 2019. And you can again see that, you know, even starting at age 25 in non-metro areas, this overall percent change increase in mortality, specifically compared to urban and specifically for this midlife group. And additional, so the opioid crisis, it was an important uptick, but again, we saw that crisis in both urban and rural areas, right? And so if we break down the cause, these mortality causes specifically, again, for this midlife mortality and comparing those two time periods, rural areas alone really had this natural cause mortality increase, right? So right over here, we can see, okay, the natural cause mortality really in metro areas went down while rural really increased. So the big question that really I think is very intriguing is like why this is happening, right? But really this paper just again is an overall overarching view. We break it down by sex, we break it down by race and ethnicity and regional variation. And again, this is sort of like an intro to other work that is to come. Okay, so data for this project came from the National Center for Health Statistics. It's mortality data on CDC Wonder. And again, sort of how they have their data sort of shaped how we could, you know, do this analysis. But in general, we decided to split this analysis between non-metro and metro, and we examined by 5-year age cohorts. And again, this report, I'll talk about differences from sex, race, and ethnicity and regional state variations. Due to data limitations, we couldn't get at like the county levels. We just used metro and non-metro and looked at state level data. And again, we used 2 3-year averages to compare. The way the data is set up, we kind of had to start in 1999 with how the codes are set up and how you define mortality. And the ending period, of course, we didn't want to include 2020 in this because lots of crazy things happened. So we did 2017 to 2019. And again, we define natural cause mortality as deaths from natural causes, which is essentially excluding accidents. So we're excluding overdoses, homicides, suicides. And in general, when we talk about mortality rate, it's measured by the crude death rate. So number of deaths in a given period divided by the initial size of the population. Okay, so now into the data and fun charts. Again, so now we're just looking at this specific section of time, right, from 1999 to 2019, and comparing non-metro to metro mortality rates. And again, we can really see this divergence toward the end, and differences in the fact that, you know, not only did non-metro increase and metro decrease, you know, but also the gap is growing over time. And again, if we break it down by age groups, so again, now we're just looking at this prime working age natural cause mortality, we can really see that the age group that's affected most is this 25 to 54 years old. And we kind of define this as a prime working age group of people. And again, that's sort of what this report will now focus on. So breaking it down by sex, and not only just non-metro metro, this one we looked at the 6 categories. And again, this is interesting because you can see really that the females actually had greater increases than the males, which I think is a very, it's interesting finding. So really we can see, especially a non-metro female had much higher increases than even non-metro males. So again, this is just non-metro. Okay, so now, sorry if it's kind of hard to read. These are just the leading causes of death from natural cause mortality broken down by the 2 sexes, females on the left. And again, we can see specifically like lung disease and other things over time, they're increasing, right? So the natural cause mortality for males and females over time are increasing. But also you can see the overall increase in female natural cause mortality is really increasing when you compare it to males. Okay, breaking it down by race and ethnicity, the non-metro prime working age natural cause mortality increased, specifically for non-Hispanic, Native Americans and non-Hispanic white males and females. And non-metro prime working age female natural cause mortality increased more than male, and it was over double for non-Hispanic white females. And not shown on this, an important note to think about is the levels of where these started. So while there's been big changes with the non-Hispanic AIN population and non-Hispanic white, the levels of Hispanics and Blacks mortality were actually higher, right? So we see bigger changes in these other groups, but the levels of the others started higher than this. Okay, breaking it down by region now, which, you know, this kind of gets to Andrew's earlier question to see like, okay, what's happening overall in these different regions. The South has the highest non-metro natural cause mortality overall for men and women. And overall, all regions actually saw an increase with the least amount of change happening in the Northeast. And even more interesting, if we break it down by state. So again, this is just for non-metro counties at the state level. We can kind of see the females on the left and the males on the right. And we can see the line like over time. So the line in the middle is over time comparison of the two. We can kind of see groupings. So it's interesting to see that most of these states, except for a couple outliers here, are grouped. So, you know, the southern regional states are up here. There's a couple outliers in the west over here for females. And really you see these trends, these sort of regional trends with a few outliers. And we can really see that over here for males, the change in more New Mexico and Arizona really up there with the southern states. Okay, so overall conclusions, we really, you know, have seen this gap in the data between the urban non-metro mortality rates and the rural rates. And while they're both impacted, the natural cause mortality deaths are really only increasing in these rural areas. And specifically for females over males, when you look at the sexes, the females are really impacted more. And the change really has specifically for non-Hispanic white and non-Hispanic AINs over the past 20 years have really increased. Oops.
What's going on?
And then basically an overall, sort of idea is this suggested convergence of mortality rates, where the highest groups are not decreasing, but the lowest groups are increasing. And future research to come that you'll hear soon will explore other health behaviors and conditions present in rural areas that might help explain this growing rural prime working age natural cause mortality. So we'll hear case study things later, and there's other research coming out from the SPG grant, hopefully in the future, that we'll dive into this a little further. I'll put a plug for USDA and ERS here, and I'll leave it at that. So, and this. So.
I'm sorry. Can you just go back to the female male? The pregnancy related one was very interesting. And I just didn't get a chance to look at it, given what Marty talked about this morning. Okay.
Okay, so the pregnancy related right here is obviously going to be down here for females. I tried to compare, so like looking across, they should be very similar, except for obviously that one. So, but yeah, I find that very interesting. That has really that change has really gone up.
Thank you.
Yep.
Regional distribution slide. Yes, this one. Okay,
Sure.
This is why I'm clearing.
Yeah.
All right, I think, so we're
Anything
gonna
else
have
for
Sarah,
clarification? Or-
I think,
No?
yeah, we'll kind of,
there any clarifying questions, otherwise we'll have more discussion after Sarah's, both papers we discussed.
Yeah, so Kelsey set the stage. Wow, that microphone is really loud. Woo. Pipe down my, yes. Kelsey set the stage for this paper and kind of raised this question of what on earth is going on in the last 20 years in rural areas, particularly among white women, that's causing their mortality to increase by a not small percentage. Okay. So Kelsey mentioned this work is part of a strategic priority grant that ERS funded, because this is kind of a priority area for, okay, this is a priority area for USDA. And the caveat is, David has done some work on health and Liz has done some work on health, but we're not, we're not really health economists, we're regional economists. Now I don't know how to advance the slides. Can
you see the cursor over to the?
Okay. Okay, so as part of this project, we said, let's get out into the real world and get boots on the ground and kind of better understand what's going on. And because we're economists, we thought, let's look at the impact of this mortality that Kelsey mentioned on rural labor, on the rural workforce, because we have such tight labor markets right now. And in rural areas, the labor markets were hit even harder during COVID. And if prime age working people are dying of natural cause things, then it seems obvious that there's a lot of illness and disability before that mortality occurred. Okay, someone from CDC is in the back nodding. Thank you, I appreciate that. So this is the work. So we're going to tag team a little bit because we've got some of our junior scholars that went out into the field, and so they're going to talk about their case studies, and I'm going to set the stage because I'm the old lady. Okay, so Kelsey kind of showed metro, non-metro, but this is the same data at the county level. We took a 5-year average, so we had a little bit more mortality. And the yellow counties have much higher prime age natural cause mortality. And the gray is at the low end. So in Missouri, and whoever asked the question about the regional, so Missouri is way far away from all the other Midwest states, right? And so you see that, the northern half of Missouri is very much like the Midwest. And the reason Missouri stuck out compared to the Midwest is the southern part of Missouri, really culturally, economically, is much more like the South. And so we see that in death rates. We see incredible death rates down here in what we call the Blue Heel of Missouri, cotton, rice, Mississippi Delta. Conversely, we saw some relatively low mortality rates in other parts of Missouri. And it kind of correlates with this map. I have just this topo map. You can see the Delta, essentially, and how the topography and the culture and the economy are kind of related. And then here is Little Dixie. This was also originally a lot of slave-owned land. And so Columbia is right here. So we're in part of Little Dixie too. So there was a little bit of cultural similarity here and here. Whereas the upper part of Missouri, very much like the upper Midwest, more like Iowa. So we're using Missouri as a case study, partly because Kelsey and Liz are in Kansas City, Missouri, and I'm in Missouri. But we're using Missouri also because Missouri is a very diverse state, and we can kind of get an idea of what's going on in the upper Midwest, what's going on in the South, and then this area is the Ozark Mountains, which has a lot of cultural and economic similarities to Appalachia. Okay. They'll have to wait. Okay. So I'll go through, I'm not going to delve into this slide too much. Essentially, we're looking at with these case studies, we're trying to get a better understanding of what's going on really with these case studies. And so we're both interested in the impacts of mortality on a workforce, but also kind of the impacts of illness and disability on the rural workforce. A little bit more data that Andrew put together using the same CBC Wonder that Kelsey just showed you. We wanted to just break it down a little bit more regionally. So we see the Ozarks and the Delta region. These regions are the Missouri workforce regions. And so we can get workforce data and workforce representatives for these regions. Those two regions are the highest in terms of natural cause prime age mortality. So it's the red and the orange on the top. And then the Northwest Missouri is not the bottom, but towards the bottom. The bottom, of course, is kind of the Kansas City metro area and the St. Louis metro area. So you really see the rural urban divergence there. Similar sort of thing for the US. So in this research, we're using these Missouri case studies to kind of inform future work. Kelsey has kind of set the stage with Liz and David in terms of some basic statistics, kind of understanding what's going on. And we're getting out there and kind of saying, is stress? Is this obesity? Is this access to healthcare? What is driving this? And we're just trying to get out there and talk to healthcare providers, workforce development, local elected officials to get an idea of what's going on so that we can assess these questions. You know, how is this mortality affecting labor markets? That is eventually going to affect the economy if this keeps going on. A sub question that kind of came up as we started doing these case studies is it's affecting the healthcare workforce alone. Who are the nurses that do the majority of the primary hands-on care in rural areas? White prime age females. Okay. So that's kind of our research questions. And then here I'm going to turn it over to Andrew, who's going to talk a little bit more about some of what he did and the first case study in Northwest Missouri.
I'm Andrew Van Leuven. I started helping with this study as Sarah's postdoc at Mizzou. Now I'm at Oklahoma State University. So moving states, but I still have been able to continue working on this. So Sarah kind of talked already about the areas that we've been focusing on, but before we really wanted to go out into the field, we wanted to make sure that the data are behind our assumptions. And so this is a LISA map. It's a map that shows spatial autocorrelation, so clusters of similar observations. And basically what you see is the Ozarks and the Boot Heel are part of a cluster of high concentration of this mortality that we're measuring. And Northwest Missouri is a concentration of low mortality. And so we were able to use our connections with the state extension and other people in the University of Missouri to find folks to go out and talk to. So Gentry and Harrison, and actually a couple other counties, Nottoway County, we were able to go do a lot of visits, Mark White and I. And then Scott and Mississippi counties down in the Boot Heel, or kind of the north side of the Boot Heel, not all the way down. That was just last week, right?
Yes.
Last week. So it was bleeding edge research. And so just to kind of show, we already looked at it, but this topography map, you can really see like the very flat part of the state is just, kind of just matches, aligns with that. So I think I'm also talking about so I already kind of just breezed over it, and it's a pretty standard, interview or participant recruitment procedure that we integrated a lot of stakeholders, a lot of important people that were able to help connect us with folks up in Northwest Missouri and Southeast Missouri. The big difference though is kind of ex ante, ex post, whatever, we're detected a little bit of differences with social capital in terms of the number of people that were just happy to jump in and participate with us. Oh, there's something going on. Let me talk to so-and-so and maybe they can also visit. And Mark and I talked to somebody and said, oh yeah, we're going to Albany, Missouri tomorrow. And the person said, oh, my sister or not, my cousin is the hospital administrator. And that's who we were scheduled to meet with the next day. So Southeast Missouri, I wasn't in that interview, but I think the consensus was there's a lot kind of more reticence to be part of that. So that might kind of illustrate some of the differences in our case study. So big list of folks that we talked to in Northwest Missouri, workforce development, economic development, clinics where the kind of chief healthcare provider was a nurse practitioner, and then also a couple hospitals where there's a variety of MDs and DOs. Really, really good way for us to see the region. And so there's no way we could talk about everything that we did over 3 days and 11 interviews. But some of the emerging things that we found, and a lot of these were things where we had structured the questions well enough that we weren't really trying to get them to say what we wanted them to say. And chief among them was mental health. We really asked a very vague question. What are the chronic conditions? And I would have guessed diabetes, hypertension, whatever. Mental health was the number one. I will cede my time. Poverty, food deserts, and isolation were the other ones, but I want to make sure Kelsey's here.
I'll jump up here real quick. So you saw Andrew's long list of participants in the Northwest. This is my shorter list in Southeast Missouri. So again, maybe a little more reticence in like wanting to talk to people or getting connected down there in that area. Just real quick, Southeast Missouri, again, something that came up, which I think was similar to Northwest, was poverty, was brought up a lot. And really this idea of intergenerational despair. So the word despair was brought up, and this sort of cycle of being in poverty and sort of not being able to get out in relation to health, and how that affects health, both mentally and just overall in general. In food, calories, again, food deserts were an issue. That's the little tiny grocery store that was in one town that we visited. And again, with these like chronic conditions, when we're thinking of natural cause mortality, transportation was a huge issue that was brought up by almost all of the 4 people that we talked to. And again, poverty as it relates to transportation and really getting to these services. So that was really quickly, but I think Sarah's back.
Oh, good, we're so fast. Okay.
Sorry.
No, it's good. So we tried to kind of pull together some of the consistent themes, and Kelsey just mentioned transportation, and Andrew's slide, he actually had a slide with the bus. So the northern area, which is a little more affluent, I don't know, it just doesn't like me. I was going to show Barney the purple bus. Okay, well, never mind.
There we go.
There we go. So they actually have a bus that they had to purchase to bring people, because if people are not getting regular treatment for chronic conditions like diabetes, things go downhill pretty fast. Okay, so the more affluent community had a bus, but in the South, there seemed to be more of this kind of culture. The providers had to be very creative. Go ahead, go
I was
ahead.
just gonna say, and also just sort of, they had to be creative in the fact that they sort of knew that there was potential for non-compliance. So if I say, okay, come do a follow-up appointment, the providers sort of knew that that not necessarily wasn't gonna happen. So they tried to be creative and work with these patients to try to get them the best care, whether that be like telehealth was brought up, or just other ways to try to get people care, knowing that these were issues in the area.
Yeah. Yeah, so some of the consistent themes are poverty, particularly the intergenerational poverty, food insecurity, the transportation, the isolation, just the access to clinics. Missouri had a lot of hospital closures because we did not adopt Medicaid expansion until this year. So we had a lot of rural hospital closures, and that kind of came through. The mental health, and the fragility of these rural clinics. So some of those collages of pictures are just these little hole in the wall, but that's their local clinic. And if the provider leaves, and a lot of times it's a nurse practitioner, not a physician, if that provider leaves, they feel like it will never be filled. So everything is just kind of hanging by a thread in these communities. We did like the sense of community that we saw in Northwest Missouri, and in Southeast Missouri, the sense of creativity, like Kelsey mentioned, problem solving, trying to anticipate that there's going to be food challenges, that there's going to be transportation challenges was really cool. So overall, the takeaways we've got from this thus far is that we're trying to put a face on the data. So Kelsey kind of showed, this is what, inside the Beltway, they're kind of looking at these CDC statistics, and so we're just kind of saying, what is really going on? Trying to put a face on this, trying to better understand. And we have this Venn diagram up here. And, this kind of gets to John's comments about endogeneity on Brian and Claudia's paper. You're never going to be able to do a regression on this without endogeneity, okay? Because what is this mortality that Kelsey explained to us? It's everything. It's mental health, it's chronic conditions, it's poverty, intergenerational poverty, isolation, lack of transportation. Broadband is getting better in both of these regions that we studied. Both case studies that came up, that broadband is getting better. Still isolation, the food deserts, the food insecurity, the fact that we just want calories, we don't care if they're healthy or not, we just need calories. This is just such a complex problem. And, as economists, it's easy for us to say, well, get some data, I'll run a regression. And this experience has taught all of us that this is such a complex problem that we kind of need to put away this idea of doing a regression and having it not be endogenous and take a deeper look. And so I mentioned Steve Deller is a fellow of the North American Regional Science Council, and he's also a AAEA member. And in his recent fellows address for the Regional Science Association, he talked about these wicked problems and how things are everything drives everything in these small, insular, rural communities. And there's been some other papers in the regional science literature recently talking about a more systems approach to solving and better understanding and coming up with policy levers to solve these kind of wicked problems that nothing in a regression is going to be able to figure out. So I kind of put that up there. But like I said, we're just putting a face on the data. We're allowing ERS. They have limitations on this kind of stuff, allowing ERS to live through us vicariously, and our extension work, and kind of bringing the extension work, the work that we do out in the field. I know a lot of you in the audience do extension stuff, and working with the ERS researchers has been awesome to expose them to what is going on the ground in these rural communities. So John will discuss.
Sarah. Kelsey.
Trying to find this. I don't want to see. Oh, there's the Zoom up there.
Appreciate the chance to live vicariously through Sarah and their work in Mizzou and soon to be University of Illinois, right?
Yes. Andrew, I can't get to that bar. Like, I want to stop screen. I don't know. Oh, is that it? Oh, cool. showing my age.
I think you might just have to be on two screens.
Okay, I'll put Amber in charge.
Something just happened.
Okay,
You got it.
okay,
So.
sorry, John.
Then I have to find mine somewhere here. Let's see. Still open? Isn't it? Okay.
Yeah.
What happened? All right, I'm not sure what's going on. And then, so, yeah, I'll start with. Oh, I just seem to have jumped over a slide here. Okay, so yeah, I'll talk, have some comments on both papers. So in the case of the research reported by Kelsey, they were looking at trends in natural cause mortality, prime working age adults, and over a 20-year period in metro versus non-metro by sex, race, ethnicity, rurality, region, and state. And I won't spend time. I mean, you heard her summarize these findings, which I think are really interesting and important. I guess one question I had, you know, in looking at these findings is this all brand new? I mean, because it really seems, you know, very important. I know David McGranahan, I was his branch chief several years ago, and he was presenting some of these results on changes in natural cause mortality and how they differed across the rural urban continuum. And it was quite striking to me. And I just thought, man, you gotta get the stuff out there, you know? And so I wonder, like, is this really, you know, how new is this? I think this is really well motivated. And so it looks like it can really make a major contribution to, you know, sort of like establishing some basic facts, you know, that maybe people aren't aware of. Kind of on the order of, you know, remembering Case and Deaton's work on deaths of despair and so on. And, you know, this is really, I think, important. So I think it isn't, I guess I'd want to hear more about what the literature does say, if anything, about that. And I think the study makes a very strong case about the need for more research on the causes, and taking Sarah's point that, you know, you can't solve everything with regressions, but I do think that we, you know, maybe all avenues, all methodological avenues should be pursued, you know, and let many flowers bloom or something. But there seems to be, you know, a lot that could be learned. I had just one minor point about the convergence issue that Kelsey, you mentioned on your last slide. I wasn't entirely sure what you're referring to. So there may be, or maybe there's more evidence on that. What you're talking about there with the convergence could be helpful. But I think, you know, in terms of looking at the effects of, you know, sort of factors that may be the causes of this, you know, definitely, and I don't know the literature, but, you know, you mentioned looking at health behaviors. I think research on maybe underlying differences in health behaviors, maybe differences in education and income, some of the usual suspects, culture as well, you know, but then access to and quality of healthcare and health insurance seems to pop out in my mind. And so I wonder, like, how much of these differences can be explained by differences in access to healthcare and health insurance. And then I also, like, this is my own soapbox issue since I've been at ERS, which is, it feels like, you know, since I started learning about US rural development issues, you know, I became aware of, like, how much literature there is on the problems in rural areas. We have no shortage of literature on problems. And, you know, I guess I'd like to see more on, you know, it's good to identify the problems, but then we also need research on what works to address the problems. Yeah, so that's my plug there, you know, for more research on those issues. So that's, whoops, what am I doing? Then I go back and talk about Sarah and group's presentation. So I think, yeah, this is obviously, it's a work in progress. So, you know, I appreciate, you know, as Sarah said, you know, you have all these interrelated problems, and so I guess I was kind of left wondering, like, what the main question is, you know, like, if it's really looking at labor market impacts of increasing worker age mortality, then, you know, how are you going to get at that? I guess, you know, like, I do appreciate, like, combining qualitative qualitative with quantitative research methods and just trying to answer questions. And I know it's a real challenge. I'm a novice at it myself. We had a ERS report that hopefully will come out sometime soon that used a combination of, some of these methods with key informant interviews, as well as a survey and so on, to try to really get at what was going on in terms of healthcare, what factors affect healthcare provision in some of the same regions. And, some of the comments I got from reviewers, some of the reviewers were experts in qualitative research methods. And I just realized, like, based on the comments I got, like, how naive or how uninformed I was about qualitative methods. And like, there are a lot of, standard ways of sort of validating, the qualitative data and so on that I was, I have to admit, I wasn't sufficiently aware of. So anyway, just a suggestion, to maybe think about the methods, review the literature on the methods a bit, and see how the methods will link to, what questions will you answer with which methods, And then I think it seems you anticipate this, or you're using secondary data, but it's sort of not clear to me, like, how will you combine secondary data to support the analysis of the primary data that you're collecting? And then also the contribution to the literature and to policy debates. I think obviously it will be important to highlight these, over these themes of the interrelated problem areas, but maybe, if there's a way to kind of go beyond that to more specifics, that'd be great. So, just some thoughts on these two papers, and I'll open it up for other, or I guess I could give do you guys want any time to respond to those, or do you want to? Okay,
That's good.
sure. Yeah. Okay.
I'm very much interested in the regional disparities. And this is my study. And I've taken a lot of thoughts. Some of them are how the population has changed during the research period, because there might be some differences in composition of the population because of immigration, out-migration. So the ethnicity or race and ethnicity might change. Also, there might be changes in workforce. You mentioned poverty, you mentioned remoteness. We know that low-income families very often struggle with health issues because they work alone, they have 2 jobs, they don't care about their health because they don't have time, and they have other reasons like poor health insurance or no health insurance. Also, there might be a good question: what the workforce involved of the how is the women involvement in the workforce during the last 20 years? Because maybe it changed. They were like stay-at-home moms 20 years ago, and now they work. They might have 1 job, 2 jobs, 3 jobs, and they are significantly tired and more sensitive to.
Yeah, I think, you want to see if you want to unmute David, because David has had a lot of hypotheses about that a generation ago, rural.
How do we do that?
Were homemakers, and now they're holding down 2 jobs, they're often the primary breadwinner, and they're taking care of their elders, their parents, they're taking care of their kids. They may be taking care of their husband who has depression or opioid issues. They're not taking care of themselves, and it's stress, and like you said, a lack of time.
And it's, yeah. And I've studied in the different countries on these issues, and they are integrate definitely. And we found these results not only through reduction analysis, but we always use.
They're not muted.
So people would ask just a particular institution or people in like a local people in interviews to see the problem from their perspectives, so that we have an explanation not only through secondary or primary data through online survey or into interviews, but the certain structures interviews, but we also make focus groups and interviews with the counterparts for the hospitals or institutions to know what's going on the other side, so that we can match the information. And also, I would like to offer a lot of primary data that we just collected at NCR CRD, it's called NCR stuff. Next slide, you might have heard about that from Maria. And we collected data from a different.
I'm sorry. We have another paper to present, so I think I might have to interrupt you. Maybe you can just meet after.
Thank you.
And
Thank you.
Okay. No. So I think apologies to anybody else that had questions. I'm gonna go ahead and maybe you can set up.
Okay.
There was a request that when you speak, be closer to the microphone so people on Zoom.
I did get it on here, so I think I should change. Oh, you changed it. Just change it. Okay, then I'll. I got it open. Let me do the screen share real quick. Okay.
Perfect. Well, thank you, everyone. Today, I represent the perfect example of a double imposter syndrome. I'm not a regional economist and neither I am an health economist, but I have ventured in both fields, and I have the pleasure to know Anders Van Sant when he was a PhD student at Colorado State, and now we are collaborating as he is a faculty at Wyoming. And we share some of the common interests. I'm by training an industrial organization economist. So he's teaching me more regional science, I'm teaching you more IO, and we come up with 12% of a paper today. So the reason why I want to point this out, Anders was supposed to present, he had a family emergency. So literally this presentation came together in the last 48 hours. So I take full responsibility for all the errors, and there will be many. So, but regardless, because of personal issues, we were hoping to have a much better product to present to you. But at least we hope that the research idea will be clear. So if we consider a little bit of so I'll be talking about hospital presence in the metro areas and death rates, in particular COVID death rates. So some of the trends that were already mentioned here at length, the healthcare industry has become consolidated. There's been a large decrease in number of hospitals, especially in rural areas. There's been a decline in hospitals overall around the United States. That is due to consolidation, hospital mergers. Also, the number of physicians have been higher now by hospitals 44% of primary physicians in 2000, in data for, I believe it was 2016, worked for an hospital at this point. Different research exists looking at tracking rural access to healthcare, specifically rural hospitals. There have been 138 closures since 2010, and 450 rural hospitals still are in risk to close. It's not just a matter of units closing, because you could have the closure of a very small unit and then in a neighboring county that still is the same hospital, I think it's a hospital service area, you will have a bigger facility offering more services. The problem is that with hospital closing, a lot of the services are also disappearing. 200 rural hospitals stopped providing all the services in the last decade, roughly, and more than 300 facilities ceased providing chemotherapy. So these are all issues. And if we look at not just in terms of what they offer, but people in this room have done research on this topic, looking at how number of hospitals are associated with economic outcomes. Recent NBR working paper by Volger looks at works very hard to identify a causal mechanism between hospital closures and a series of other economic indicators, such as local employment, per capita income, labor force participation, housing rental prices. More research both in the rural health, some published in APP, in some of our journals. I'm not citing, I mean, there is a lot. Investigating at the effects of rural hospital closures and economic impacts. Now, there is something that we were interested in. At the beginning, we were thinking about looking at different type of health outcomes, so looking at obesity, but they would say that there is too much, there are too many mechanisms that are there in place. So let's look at one statistic, which is mortality rate, all causes, okay? So not the other presentations look at specific types. We look at all causes mortality rates. So there is actually research showing that you have higher mortality rates, either following hospitalization in rural areas where you had closures of hospitals. So the same areas where you can have a closure of an hospital might become part of a larger hospital service area, which means that it could be a county that is not used to be served by a hospital, now is served by a hospital in an adjacent county, okay? So they are in the same HSA, but they used to be two different ones, there was a closure and so forth. Rural zip code experiencing hospital closures had higher rates of admission and higher rates of age-adjusted in-hospital mortality. And this should speak to some what was already presented, what were this area where there were the closures and the higher mortality, higher poverty rates, lower share of non-Hispanic whites, lower average education. And they were areas where actually there were probably some unused capacity or excess capacity. The hospitals were not in use. So they were, I mean, we don't talk about money. Someone else talked about revenue already today, but there were probably hospitals that were not having, not in the black, they were bottom line. One thing that I want to mention, this is something that I was trying, I could not find a lot. This is a medical journal. They were looking at mortality rate in patients admitted in hospitals in non-metro areas versus metro areas. So is there a different risk factors? Are people in metro areas substantially different? They have riskier features. And so one of the things that they found through the hospitals, they were looking at actually the likelihood is mortality rates sometimes in the metro areas in hospitals can be lower in hospitals. Why? Because, so if we were looking only at mortality rates in hospitals, we would have a problem. Why? Because often when you have an emergency care or they might not have specific units, they are moved to another hospitals. So it's just a matter of there is a different risk, there are different risk factors, or just patients that are more likely to die if they stay in a rural hospital can be transferred to non-rural hospitals. And that was something that actually they found that that was the case. So these are, we were, because of this, then we got to the, I mean, you're going to have hundreds of papers on COVID for the next year. So one more. So, and so what we're thinking is, okay, so we know by looking at statistics, and this is a report from the USDA, actually, this is one report of Rural America, one of the latest ones. Looking at the, I'm not going to types of poverty, but this graph shows that if we look at metro and non-metro areas, cases, number of cumulative COVID-19 cases per 100,000 residents, you would see that at the beginning of the pandemic, you will, very beginning, they were the same. Actually, the cases were much higher rates, metro area, because that's how the spread began. But pretty much after the first summer wave, rates were higher or same in the metro area than in metro areas. So this is something that happened consistently. So we started thinking about, we know that there's been a lot of hospital closure, the number of hospitals has decreased. There are a lot of issues related when people are hospitalized because of COVID. In that case, you might not have the possibility to transport them to other places. We know that in rural areas, there are papers where analyzing the risk factors of individuals in non-metro areas. Everything that goes from what Sarah and others mentioned, higher poverty rates, lower education, higher risk, more of the higher obesity, food insecurity. So pretty much there is a higher chance that if you get COVID in a rural area, you will get a more severe case, higher risk of hospitalization, and a higher probability that you can get hospitalization per capita, and you can get it in severe. Also, the recent Rupert report shows that even if we compare non-metropolitan areas with metropolitan areas mortality rates due to COVID, the red light, which is non-metro area, the red dotted or dashed line, is above the blue one in metro area for most of the durations of the pandemic. So when we're trying to look at is, what is the relationship between death rate present hospital per capita in rural and metro US, just how this relationship pans out, and whether the presence of hospital contributes to excess death, net of COVID-19. What does it mean? We know that there is, according to the CDC, excess deaths can be defined as the difference between the observed deaths, some number of deaths in a specific time period, and the expected number of deaths in the same period. So we're going to look at the effect of hospital prior to the pandemic on death rates, assuming our identification strategy will convince you, which I'm sure it won't. And then the effect of 2020, we want to account for COVID-19 deaths. So in a way, what we are trying to find is pretty much the changes in that DOC is the number of death. So if DT is the total number of deaths during a COVID year, you have number of COVID deaths and other causes. The other causes are, we have a number that is D expected, D0. And there are all those people who would have died anyway because they were old, they already had heart issues, they already had pulmonary issues, and all those deaths that also could have been avoided because those are non-COVID deaths that occurred because hospitals were full, people were not getting chemotherapy, people were not able to access the appropriate care, there was a switch to telehealth and so forth. So we want to determine that whether hospitals had anything to do with that number. I mean, you cannot prevent deaths from COVID-19. Many people will die because it's a bad disease. Some people will be affected by it, and this will occur. Problem is, there are estimates provided by the CDC of D0 or the expected deaths. We are using sort of an agnostic way. We don't know what that is. And we try to estimate we do not observe D0. We try to see whether the hospital presence pushes this excess death towards more negative value. So there were more unavoidable deaths than unintended deaths, or more positive, there were more of the unintended consequences that compared to people who would have died anyway, COVID hadn't been around. So how we do that, pretty much we look at data for 2019 to estimate a baseline effect of a number of hospitals per capita on death rate. And then we use 2020, 2022 data to estimate a model where we have number of hospitals here and a series of control, which are mostly risk factors associated with higher mortality rates. And also we regress the number of COVID rates on number of cases and the same number of controls and number of hospitals. So our idea is to get estimates of these three. We try different identification strategies. I'm presenting one here. We use property tax rates as a lower location cost for hospitals, cost of burden of housing expenditures. We tried a percentage of individuals in Medicare, Medicaid, uninsured. We tried a lot. These are one progression from today. COVID cases might also be endogenous because they can be related to other factors which we're not capturing. So we didn't come up with anything better for percentage of people who voted for Trump in 2016. So I'm going to skip on all the data sources also because probably I'll get them wrong in summary stats. What we find in our model, when we instrumentalize the number of hospitals per capita, we do find a negative relationship between number of deaths per capita, all mortality, all sources, and per capita hospitals. This is well, you'll see there is a large number, but you see it's not. It's large because of something I'll mention in a second. It is actually not. It is the marginal effects corresponds to a 145% increase in number of hospitals. So you have to more than double the number of hospitals to achieve something that would be close to probably a 4% reduction, which is not going to happen. I mean, the identification works for some of the years for 1919, works for 2021. It really doesn't work for 2020. We could not find any statistical significant relationship, but the identification strategy, really, we don't pass any test. So it seems like we have a problem when we try to understand whether or not there was a relationship between COVID deaths and hospitals. So concluding, the one number that I want to present is this, because we don't find any relationship between COVID deaths and number of hospitals, we exclude it from our calculation of excess deaths effect. We cannot calculate standard errors. Those are separate equations. We should estimate them all simultaneously. Pretty much, we can have a 140% decrease in hospitals. It might lead, if you believe in our identification, it might have led to 2.4 lower excess deaths per 10,000 people during COVID. So had some hospital not closed, you would have avoided some of those unintended consequences, death. And we have a lot of issues. These are very preliminary, so please, I know some people were taking pictures. Do not cite us because this was not what we intended to present originally. We had to look at, should we focus on counties that experienced hospital closures in the last 5 years? Should we look at system of equation? We tried to use some spatial econometric elements, but we decided to go back to basic, start simple, and then add that later. There is a possibility of exploring more dimensions of rurality, not just focusing on the groups 4 to 9, but looking at major adjacent areas, non-major adjacent area, mostly rural areas, entire areas, and so forth. So thank you. Again, I'm not a regional economist, so please take it easy, guys. Thank you.
So, thank you, Alessandra.